Hi, my name is Brooke Brennan, and this capstone presentation is to meet the graduation requirements for the Master of Science in Allied Health through Oregon Institute of Technology. Over the next 40 slides, I will take you through the evolution of my research question and provide insight into the clinical data gathered for this extensive analysis. The initial research question for this project was the effects of socioeconomic standing versus geographical location on peripheral arterial disease and venous disease, more specifically, atherosclerosis versus deep venous thrombosis. My theory was that there was an increased prevalence of lower extremity arterial disease in rural areas and an increased prevalence of deep venous thrombosis in metropolitan areas. I theorized that these incidents would be evident because of the tobacco use in rural areas and intravenous drug use in metropolitan areas. This theory was founded on evidence-based research that has shown that rural areas have an increase in tobacco use. See Roberts, 2016, and metropolitan areas have an increase in intravenous drug use. See Mack, 2017. However, after gathering data and extensive conversations with my committee members, it became evident that there were limitations with the socioeconomic aspects of this research question. Because of these limitations, which will be further discussed later, the question morphed into what it is today: the effects of geographical location within Washington state on peripheral arterial disease and venous disease, more specifically, atherosclerosis versus deep venous thrombosis. Now that we've addressed the progression of the research question, let's dive into the background information for this project. First, we need to address the nomenclature that will arise through this presentation. ABI stands for ankle brachial indices. ABI with tread stands for ankle brachial indices with treadmill. DVT stands for deep venous thrombosis. EMR stands for electronic medical record. IVDU stands for intravenous drug use. LEA stands for lower extremity arterial. LEV stands for lower extremity venous. PAD stands for peripheral arterial disease. PVI stands for Pacific Vascular Incorporated. SVT stands for superficial venous thrombosis, and VP stands for Vascular. This project was completed in conjunction with PVI, or Pacific Vascular Incorporated, out of Bothell, Washington. PVI was instated or incorporated in August of 1986 after the purchase of 5 labs in the greater Seattle area, as well as programs through the Institute of Applied Physiology and Medicine. It has been an employee-owned company since 1999, and they currently have 28 locations. They remain in a professional association and continue to train students to this day. This diagram shows the inpatient and outpatient facilities associated with PVI, as well as their counties of residence. There are 3 locations that were not included in this project of their 28 locations. Data for both Viva locations, their lab in Bellevue and their lab in Issaquah, as well as their Box Bar location in Seattle, were not included in the final results, as these locations were not active for the entirety of the assessed time period and had 5 or less relevant exams for this research. PVI utilizes a system called VascuPro to chart their exams and store their patient data. Access was granted to the system by reinstating my previous PVI credentials as an employee. This image is an example of how information appears within the VascuPro system. A further explanation of this system and the gathered data will be further discussed in the methodology section. Before we move on to methodology, let's take a look into some background information regarding this topic. This research presented a unique opportunity as I could find no studies that compared lower extremity venous disease and peripheral arterial disease based on their prevalence on geographical location or population density. There were studies that focused on education level or household income and geographical location, but they only focused on one form of these diseases and did not compare their prevalence in a side-by-side manner. Because of this, though, finding relevant research articles was a difficult task. Therefore, I focused more on the risk factors most prevalent in the rural and metropolitan areas of Washington state. As mentioned, previous evidence-based research has shown that rural areas have an increased prevalence of tobacco use, see Roberts 2016, and metropolitan areas have an increased prevalence of intravenous drug use, see Mack 2017. Focusing more on these risk factors in relation to Washington state, we see the increased incidence of intravenous drug use within Seattle, the largest metropolitan area of Washington state. It has been reported that intravenous drug users are now experiencing a secular trend in increasing femoral injection. This practice has been associated with a high rate of medical complications, according to Coffin on page 371. Of the individuals who reported femoral injection, 35 also reported medical complications relating to blood clots and venous stasis disease. In contrast, Washington State Department of Health noted an increased occurrence of tobacco use within rural communities of Washington, and these findings are noted in the diagram at the right side of the screen. While there is limited research comparing the prevalence of peripheral arterial disease and peripheral venous disease, there is evidence-based research that shows an increased incidence of peripheral arterial disease in rural areas. One study from Paul in 2007 showed an increased occurrence of peripheral arterial disease among rural Black South Africans. A second study from Razaya in 2013 showed an increased occurrence of peripheral arterial disease amongst rural patients in Malaysia. I could find no relevant studies assessing an increased occurrence of peripheral venous disease within metropolitan areas. The closest and most relevant, also widely known study to this research is the Worcester Venous Thromboembolism Study from 2006. However, this study only documented incidents of venous thromboembolism within the Worcester metropolitan area. While all these studies are relevant to this research, they do not provide the insight into correlations between population density and peripheral vascular disease in a comparison nature like my studies sought to provide. Let's move on from the previous research to how the study was conducted, the methodology section. This project was designed as a retrospective study utilizing quantitative information. While this is not a quality improvement study, the block sampling method was utilized. Data was collected from PVI through their VascuPro system from a one-year time period, beginning January 1st, 2019 at 12:01 a.m. and ending December 31st, 2019 at 11:59 p.m. A total of 42,026 exams were performed during this time period. The exams that were taken into consideration included lower extremity arterial, ankle brachial indices with treadmill, ankle brachial indices as a standalone exam, lower extremity venous evaluation complete, meaning they also looked at the iliocaval segment, and lower extremity venous evaluation abbreviated, which could be a unilateral exam or just the lower extremities. Lower extremity venous reflux examinations and aortoiliacs and iliocaval exams were not evaluated for this project. For this project, 19,987 lower extremity venous exams and 5,633 lower extremity arterial exams were evaluated. The gathered data was plotted based on lab location pertaining to both city and county. The exams meeting the aforementioned criteria were evaluated based on their final report. This is an example of how the final report appears in VascuPro. The final report allowed access to assess the severity of disease in the bilateral lower extremities. The criteria for assessing the severity of arterial disease was provided by PVI. This image is provided to help recall the layout of the VascuPro system. Data can be sorted by gender, date, exam type, and all other factors listed at the top of the display. Initially, it was planned for me to visit PVI headquarters and utilize their system to aggregate the data. However, because of COVID-19, it was decided to reinstate my remote access on Citrix and utilize VascuPro from home to gather the data. This image provides a better understanding of how data is assessed on the VascuPro system. All logged patient information can be seen on the left side of the screen, while the final report is visualized on the right side of the screen. The data was then gathered and plotted in an Excel spreadsheet. This is an example of the Excel spreadsheet. Note that by the time it has been sorted onto the spreadsheet, patient identifying factors have been removed. This spreadsheet is also password protected, further ensuring patient privacy. At the beginning of this research, I was aware of two biases. the detection of cases bias, and the definition bias. Regarding detection of cases, a case may have been marked as positive, but the extent of the disease for that exam could be minimal in comparison to the other positive cases. Non-inclusive plaque versus a total occlusion. This bias ended up being eliminated since I evaluated the data from home and could see the extent of the disease for each patient. However, this did increase the timeline for the project significantly, but I'm getting ahead of myself. The second bias I was aware of was the definition bias. This related to defining the exact examinations that would be taken into consideration for this project. Therefore, it was decided to only search for the 6 exam types: lower extremity arterial, ankle brachial indices with treadmill, ankle brachial indices, lower extremity venous complete, lower extremity venous conditional, and lower extremity venous abbreviated. A bias I was not initially aware of was labeled as the information bias. As I evaluated final reports of the exam, it became apparent that not all technologists included the same information in the clinical indication section. Because these are not patient charts in the sense of an EMR, they do not contain all patient history. It's up to the technologist to ensure that their relevant risk factors are located in the clinical indication section. It was not possible to eliminate this bias because there was not access to the patient's EMRs, and therefore I had to trust the information provided by the individual technologists on their reports. As this project progressed, several limitations became apparent. Initially, I planned to visit PVI and utilize the statistics function with VascuPro. This meant I could search exams in VascuPro through the statistics function and then copy the relevant information into an Excel spreadsheet. This process would have taken roughly a 40-hour workweek, probably less, to gather all necessary data. However, due to COVID-19, it was decided to reinstate my remote Citrix access and evaluate the exams from home. With this reinstatement, however, Excel was not provided, which means I could not copy and paste the exams from the VascuPro system into the Excel due to the nature of the Citrix app. This meant individually assessing all exams. All exams. This took approximately 8 weeks, almost 2 months longer than the initially expected timeline. Prior to this limitation, the timeline of the project was impacted through the extent of the approval from the IRB as well. However, it is important to note that while this project took longer than expected, it did provide for more protection in regard to patient security. If the process had gone as anticipated, patient names were going to be exported to an Excel spreadsheet and then utilized to evaluate the abnormal cases. However, it was not possible to export information, which meant patient names were never retrieved and remained on the secure Citrix server within the patient charts. Another limitation to this study was the aspect of traveling. Because patients were not evaluated based on address, we cannot assure that every exam performed at a location is relevant to the population of that area. For instance, an inpatient at First Hill Hospital may actually live in Yakima, and therefore is not an accurate representation for the geographical location within Seattle. I've also had patients at First Hill in Seattle from Montana and Alaska, so they also may not be relevant to Washington State in general. In order to eliminate this limitation, a more in-depth study would need to be performed, which would require further consent from patients and all medical facilities associated with the PVI locations, and not just utilizing the PVI system. Similar to the limitation of traveling outside of their counties, patients have options to where to seek medical treatment within their counties. In King County alone, there are more than 20 hospitals for patients to choose from. This does not include outpatient clinics or private practices where patients can have vascular ultrasounds performed. Because PVI is not contracted with all of these facilities, we cannot ascertain the true number of patients seeking care for lower extremity vascular diseases. The only way to adequately and accurately evaluate the extent of lower extremity vascular disease for Washington is to look at all lab locations throughout the state. A further limitation was the extent of evaluated data. The initial plan was to collect data from a 3 or 5 year period. However, after running the statistics function in VascuPro to assess positive cases of lower extremity arterial disease, There were over 17,000 cases in a 3-year period. The number of venous cases alone would have been more than 50,000. Because these cases needed to be evaluated individually by me alone, the number of exams performed in a 3 or 5-year period were felt to be far too much. Finally, the last noted limitation of this project pertains to the socioeconomic status of individual patients. At project approval, the object of the research was to compare patient disease with their geographical location and their socioeconomic status. The workload to assess this ended up being more significant than anticipated. First, access to patient health information, such as their socioeconomic status, was not feasible due to patient privacy and not having access to the EMRs. This meant that all assumptions for socioeconomic status would be based on the average for the county in which the exam was performed. However, as previously mentioned, patients can travel from different counties to seek medical care, which makes this an inaccurate assessment. Second, comparing the second socioeconomic data to geographical location and severity of disease was not feasible for this project. Rather than providing clarity, these aspects of comparison provided more questions than they answered and continued to lead to further research questions. Now that we've thoroughly explored the background information of this project, let's get into the results of the research. The 19,987 lower extremity venous exams and 5,633 lower extremity arterial exams were evaluated and graphed based on positive and negative results. These results were then segregated by location of the lab they were performed at. The first table was difficult to evaluate due to the number of locations, so they were segregated further by county. They were then segregated into their final categories based on population density. Urban or metropolitan areas are defined by the USDA Economic Research Service as having more than 5 individuals per square mile. King County met the criteria to be considered urban. Pierce County, which has a population density of 476.3 individuals per square mile, was also included in the metropolitan category due to the limited amount of data for this project. As mentioned, data was segregated into 3 tables, the first being by lab location, the second being by county, and the third being by population density. This table shows the exam results based on the lab locations. While it does provide significant information, it is difficult to evaluate. This table shows the exam results by county. It further compresses the data when compared to the previous graph, but is still not as relevant as the population density in regards to metropolitan areas and urban areas. This is the final table. That is the main focus for evaluating examination results based on geographical location in relation to the population density. It categorizes everything simply and is easy to follow. Looking at the previous table, an increase of lower extremity arterial disease was noted within rural areas, and an increase in lower extremity venous disease was noted in metropolitan areas. A Z-score test was utilized to determine the significance of these differences. For lower extremity arterial disease, the value of Z was negative 3.6063, while the p-value was found to be 0.0003. For lower extremity venous disease, the Z-score was 5.2398, while the p-value was found to be less than 0.00001. These values show the differences in disease prevalence within rural and urban areas are statistically significant. I also wanted to evaluate the significance of the results based on the average of Washington State as a whole. Here we can see the results based on population density compared to the state results. You can see an increase in peripheral arterial disease within rural areas and an increase in lower extremity venous disease in metropolitan areas. When comparing these, it's important to utilize the p-value again to determine the differences if the differences are statistically significant, just as we had previously. The Z-score was again utilized. When comparing the prevalence of lower extremity arterial disease in rural areas to the state levels, the p-value of 0.01552 showed that the increased prevalence of lower extremity arterial disease within rural areas was indeed statistically significant. As for the prevalence of lower extremity venous disease in metropolitan areas, a p-value of 0.034 was noted. This also proved the increased prevalence to be statistically significant. Now that the difference has been proven to be statistically significant, we can discuss further correlations from the gathered data. The first thing that should be addressed is the risk factors that were assessed. As mentioned, the hypothesis for this research was that there would be an increased prevalence of lower extremity arterial disease within rural areas due to increased tobacco use. Risk factors were noted in the final report of the Vascular system and tracked in the Excel document. This first table shows the numbers of patients in each county that had smoking or intravenous drug use listed as a risk factor. This table condenses the risk factors into population density. However, just seeing the numbers does not indicate the percentage of patients that had risk factors, as there was an unequal distribution of patient exams throughout these counties. Again, recall that most of the lab locations are within King County alone, which skews the data into the numbers being significantly higher in King County area or the metropolitan area. Taking this information and converting it to percentages, we see that in rural areas, 52% of peripheral arterial exams had smoking as a risk factor, and 76.4% of these individuals had positive lower extremity arterial exams. Whereas, within metropolitan areas, only 46.2% of peripheral arterial exams had smoking as a risk factor, and 74.3% of these individuals had positive arterial exams. This demonstrates a nearly 6% increased prevalence of smoking within rural areas, which is consistent with the findings that were noted earlier by Washington State Health Department. Similarly, we also see a correlation for the hypothesis of increased intravenous drug use in metropolitan areas that would result in an increased peripheral venous disease. Within metropolitan areas, 2.4% of patients had intravenous drug use listed as a risk factor, and 37.8% of these individuals were positive for deep venous thrombosis. Whereas, in rural areas, less than 1% of patients had intravenous drug use listed as a risk factor, and only 30.6% of these patients were positive for deep venous thrombosis. This indicates an increased prevalence of intravenous drug use within metropolitan areas, which is consistent with that noted by the National Survey of Drug Use and Health, MAC, in 2017. A key aspect of the initially planned research was that of the socioeconomic information. Initially, it was thought to evaluate the prevalence of disease based on the socioeconomics of Washington counties. Specific vascular lab locations were segregated by counties, and the economic statistics of all assessed counties were compiled by utilizing 2 state-regulated sites. The factors evaluated included population, median home value, median rent cost, high school graduation or higher education, median household income, poverty rate, and deaths related to opioids, and how much that has increased since 2004, as well as tobacco use. The table with the data can be found in the discussion section of the written portion of the project. It was difficult to include this table into the presentation due to the extensive nature. After evaluating the socioeconomics of these areas, it was determined that attempting to correlate the aggregated data with this information would require more time than allotted for this research project. It was also felt to be unreliable to assume patients' socioeconomic status based on their county of residence and not their personal demographics. However, the patient demographics were also non-accessible. While this project itself was unable to evaluate effect of socioeconomic status on peripheral vascular diseases, there have been previous studies that showed a correlation in the increased prevalence of both peripheral venous disease and peripheral arterial disease in areas of lower socioeconomic status. See Court in 2017 for peripheral venous disease and Kroger 2009 for peripheral arterial disease. Further research should be performed to evaluate how the socioeconomic status of individuals within Washington State impacts the prevalence of these diseases. This would require access to individual patient demographics rather than those at just county level. So in conclusion, evidence of this research suggests an increased prevalence of deep venous thrombosis of the lower extremities within metropolitan areas and an increased prevalence of peripheral arterial disease within rural areas. When comparing the prevalence of peripheral arterial disease, a p-value of 0.003 was noted, whereas when comparing peripheral venous disease, a p-value of less than 0.00001 was noted. These p-values show the correlations between disease and geographical location are statistically significant. Furthermore, the incidence of peripheral arterial disease within Washington state in comparison to rural areas had a p-value of 0.01552, and the incidence of peripheral venous disease within Washington state in comparison to metropolitan areas had a p-value of 0.034. These values further suggest the statistical significance in an increased prevalence of peripheral venous disease within metropolitan areas and an increased prevalence of peripheral arterial disease within rural areas. Research also noted an increased incidence of tobacco use in rural areas by nearly 6%, which was consistent with the Washington State Department of Health. An increased incidence of intravenous drug use in metropolitan areas was also noted. This evidence suggests that the theory behind this research may be accurate. However, more research is suggested to prove this theory and the correlation. It is also suggested that more research be performed to better understand the correlation between population density and the prevalence of peripheral vascular disease. Data gathered should be utilized as a framework for future studies to provide further insight into this correlation. So what do we do with this information? This research provided a substantial amount of data. Further studies can evaluate the aggregated data to determine correlations between gender and prevalence of disease or age and prevalence of disease. However, it is recommended that further research be performed to gain insight into the geographical location of the patient and not just the hospital or clinic location. It is also recommended that this research evaluate the socioeconomic status of the individual patients in order to determine a correlation to prevalence of disease. In order to accurately and adequately evaluate the impact that geographical location has on vascular disease in Washington, all of the previously mentioned biases need to be addressed. To address these biases, future research should take place over at least a 10-year period, but a 20 to 30-year period is recommended. Data should be gathered from all of Washington and not just PVI-specific locations. Researchers should also have access to patient EMRs so as to ascertain the risk factors associated with peripheral vascular diseases. Access to EMRs will provide patient addresses, thus contributing to a more specific geographical location for the patient's disease. Furthermore, research should be performed by a team of experts working with a grant. This information provided by this research is substantial and can provide insight into geographical and socioeconomic risk factors associated with peripheral vascular diseases. However, the currently gathered information is too much for one grad student to adequately assess in a 6-month time period. There are further correlations to evaluate and understand, which would require a team working full-time. If you have any questions for the resources, these are the references utilized providing the background for this information. I appreciate your time today. Thank you so much, not only during this presentation, but throughout this entire process. I would like to open this time up for questions.